Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled The Lifetime Management of Congenital Pulmonary Valve Disease. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com all the way back in 2006. The mission of our website is really simple. We want to educate and empower patients just like you. And this webinar, which has had over 350 registrations from patients in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in what's known as listen-only mode, but I'd encourage you to submit your questions in the control panel that's on your screen. And as we look at the agenda, you'll see why. So first, we're going to do some introductions of the featured speakers. We're going to talk about fetal and pediatric presentation of pulmonary valve disease. We're going to look at the surgical management of pulmonary valve disease, the adult presentation. We're going to look at the newer transcatheter management strategies and devices of pulmonary valve disorders. One of my favorite parts is we're going to contextualize a lot of what you have heard in actual case examples so you can see how the Cedars team is approaching the congenital treatment of pulmonary valve disease. We're going to get to that Q&A session, and then at the very end of the webinar, I'm going to ask you to complete a very quick 5-question survey. So when it comes to the featured speakers of today, I would submit to you that we have a fantastic 4 with us today. And the reason I say that is because when it comes to congenital pulmonary valve disease, we have physicians who cover all aspects of it. We have a cardiologist, we have interventional cardiologists, we have a cardiac surgeon. And so let's take a look at who they are. They are Dr. Rose Tompkins, who's the Associate Professor of Cardiology at Cedars-Sinai. She's also the Director of Adult Congenital Program. She's board certified in adult congenital heart disease, and you may have seen a lot of her research and publications just recently in how to navigate high-risk pregnancy. Dr. Jay Pruetz is a professor of cardiology, pediatrics, and maternal fetal medicine. He's also the associate director of the Guerin Family Congenital Heart Program at Cedars-Sinai. He's the director of fetal cardiology, has multiple research publications as well. And Dr. Melita Viegas is the surgical director of congenital cardiac ICU and pediatric cardiac mechanical circulatory support. She's also the associate director of pediatric and congenital cardiac surgery, and she's a staff physician at Guerin's Family Congenital Heart Program. And we have with us Dr. Stephen Nageotte, who's an interventional cardiologist. And what that means is he's using very minimally invasive techniques to diagnose and treat children and adults. He's also the director of catheterization laboratory at the Smith Heart Institute in Guerin's Children Family. He's a staff physician with Cedars and Guerin's Family Congenital Heart Program. So I could go on and on about all the achievements and the accolades of this incredible panel. What I'd like to do is show you this. These are actual patient names of folks from the HeartValveSurgery.com community, whether it's Janice or Don or George or Stan, who have gone from the HeartValveSurgery.com website to Cedars-Sinai for their care. It's one thing to see some names on a screen, but it's another thing to see the actual smiling faces of their patients. Whether it's Josh or Wendy from Florida, or Jerry or Leilani or Steve or Patricia, thanks to this team, the entire Cedars team, we're taking folks in very fragile disease states and bringing them to places of great outcomes and excellent care. So with that being said, I'd like to turn it over to Dr. Jay Pruetz to begin the webinar.
Thank you, Adam. Really appreciate being here today. I'm going to talk to you about fetal and pediatric presentation of pulmonary valve disease, kind of through the lens of a diagnosis called tetralogy of flow. But this could apply to many different diagnoses that involve the pulmonary valve. You can go to the next slide. So tetralogy of flow is a congenital heart defect. The key anatomic findings with it are that it has a hole between the 2 lower chambers of the heart, a ventricular septal defect between the right and left ventricles, those are the lower chambers. It has, and the aorta is kind of shifted over this hole, so it kind of straddles over both the right and the left heart, and then there's usually narrowing in the blood vessel that goes out to the lungs, the pulmonary artery, and that's where the pulmonary valve is. The pulmonary valve is the gatekeeper for flow from the right heart out to the lungs. And so that often can be small, underdeveloped, and when we say that it's small and underdeveloped, we call that stenosis. When it's completely closed, so there's no connection, we call that atresia. And so those are the basic features of tetralogy flow, and then sometimes associated with that, you can also have additional findings such as anomalies of the pulmonary arteries themselves. Sometimes you can have an extra vein connected to the left side of the heart. Your aortic arch can be on the right side instead of the left side, and sometimes you can have extra blood vessels feeding the lungs. I'm not going to get into the details of that, but this kind of sets the stage for, with this diagnosis, how do we approach this? So we can go to the next slide. So the diagnosis, we actually can make this diagnosis in utero now. So many times, this is actually an echo here, a transthoracic echo that we're seeing on the screen. And actually you're seeing on the top part the right ventricle, on the bottom part the left ventricle, and then that red flow is across the hole between them. That's the VSD. So this is a pediatric echocardiogram, but many times we can detect this even before the baby's born. Sometimes it's not detected before the baby's born, and when that happens, we call that a postnatal diagnosis or after birth. And that can present in one of two different ways. Sometimes it's detected because the child has a heart murmur, or the baby has a heart murmur, so it gets sent to the cardiologist for evaluation. Sometimes it's because there's such obstruction to blood flow to the lungs that the baby's color is actually blue. And we call that cyanosis because there's not enough blood flow to the lungs. And then we use a number of different diagnostic tests to evaluate these children, including chest x-ray, EKG, echocardiogram, and then occasionally, if we need even more high-resolution imaging of structures, sometimes we also do a chest CT or a cardiac MRI as well to delineate the anatomy. Next slide. So this is actually an example of a fetal echocardiogram. So this is a baby inside the mom. To the top of the screen is the fetal chest, and at the bottom you can kind of make out the vertebrae. That's the spine. You can see the heart here, and if you click another time, there will be some labels that come on that kind of show you the different heart chambers. So here you have the right ventricle, there's the pulmonary valve, which is usually obstructed and narrowed, and then you can see that hole between the right ventricle and left ventricle. So this is kind of how we diagnose it. You don't really have to obviously understand all the nuances of ultrasound, but just to give you an idea, this is really the bread and butter of how we figure these diagnoses out. So we can go to the next slide. So in talking about tetralogy of flow, I'm going to just kind of talk broadly how we categorize this. You may have heard the terms before, a pink tet or a blue tetralogy of flow, and really what that has to do with is where are the oxygen levels? If the oxygen levels, we call them O2 saturations, are normal, then the baby or the child appears pink on exam, and their oxygen levels measure normally. And in that scenario, if you look at this table, and that's the second column of pink tet, they have very little obstruction to outflow from their right heart. They don't have cyanosis, so they're pink, and they have a decent amount of pulmonary blood flow. So they have enough blood flow going to their lungs, and they usually are the ones that present with less symptoms. They often will just have a murmur or maybe very minor symptoms of some increased work of breathing or congestion. Versus a blue tetralogy flows, when the O2 saturations are very low, there's a very significant amount of obstruction of blood flow to the baby's lungs, and the baby is blue and also can have what are called cyanotic spells. So these, you can kind of see these two categories are going to be approached very differently. There are also more complex forms of tetralogy of flow that we're not going to get into today, where you won't have a pulmonary valve at all, or you have anomalies of your pulmonary arteries, but we're going to focus on this main category right here. Next slide. So then how do we approach this? What are the goals of repairing this? So we know that this can be repaired surgically. The first thing is to try to figure out what's the ideal timing. Do we need to repair this in a newborn, or can we wait until the baby's a bit older and kind of figure out this surgery at a later date? What technique are we going to use? And I'm going to get into that a little bit more. And really the goals are, we want to obviously try to minimize reinterventions Ideally, this would be a one-off surgery and done, but unfortunately, that's not always the case, and you're going to learn a lot about that today, particularly because the pulmonary valve often needs to be fixed or replaced down the road. And then we want to preserve the right heart function. We don't want to overload it. We don't want to cause dysfunction of the heart. And so that plays into our scheme of what the timing of surgery and how we're going to repair things. On to the next slide. And so this is just a quick kind of chart of if you present as a baby or a young child with severe cyanosis, that means you're blue, and you are at least over 3 kilograms, you may go for a complete repair, a neonatal tetralogy repair right away. We don't have a choice. You're blue, the anatomy's good, you're a good size, we'll fix it. More often than not, though, the babies may be a little too small, or there may be other comorbidities that we'd want to do more of a staged repair. And what that means is we don't go fix everything all at once. We may actually augment the pulmonary blood flow for a short time by either providing increased blood flow to the lungs, an additional source of pulmonary blood flow, and then coming back at a later date at the bottom of that pathway at 3 to 6 months and do the complete repair. Or if we're what's so-called pink tet, you're at the very far side of the screen where you have mild cyanosis, you may not need any initial treatment. You may be able to go out to 6 months and then go for that complete repair. And I'm going to talk to you about the two general approaches to that on the next slide. And so the approach typically has to do with how much pulmonary valve there is. If you have a decent outflow tract from the right heart to the lungs, if you have a decent sized pulmonary valve, we would try to do what's called a valve sparing TOF repair. And that's under letter B there, where there is an outflow tract. And what we would do is we would leave your valve alone, and we would patch above the valve in the main pulmonary artery, and then we might patch below the valve in the right outflow tract, but not try to influence the valve too much so that it could grow with the patient. That's the valve sparing. However, if the valve is too small or too obstructed, then we can't do that, because if we did that, we would leave you with a lot of obstruction. So then it's under letter A, it's called the transannular patch, where you would cut all the way across the valve. You'd essentially have to remove the valve and put a big patch there to open up to relieve that obstruction. That would leave the patient with no effective pulmonary valve, which is okay for a time, even for years, but eventually would need to be addressed. And then in the case of there's really no valve or no outflow tract, that's at the bottom, when you have something called pulmonary atresia, you actually have to sew in a completely new connection from the right heart to the pulmonary artery, and that's called a conduit, an RV, right ventricle to pulmonary artery conduit, and that often will have a valve inside of it. The issue with that is that those are fixed size, they don't grow with the patient. So depending on the age and the size we put it in, they may have to be upsized with another surgical procedure over time. You can go to the next slide. So now I'm going to pass it on to my surgical colleague, Dr. Melita Viegas, to talk about the nuances of these different surgical repairs.
Thanks, Dr. Pruetz. So, you can go ahead to the next slide. We're going to fast forward a few years and, just focusing on what Dr. Pruetz was just talking about with tetralogy below, each one of those repairs within somewhere, it could be as early as 4 or 5 years or even 10 to 20 years, will need an intervention. Valves sometimes are valve-sparing TET repairs. About 16 to 30% of those actually require a pulmonary valve in the future. The ones that get transannular patches, they also will at some point require a pulmonary valve. And I'm actually going to let Dr. Tompkins talk a lot about indications. I'm going to try to focus on what the pulmonary valve replacement surgery is and how we make our choices for the valve. So who needs a pulmonary valve? So any patient that requires a valve in the pulmonary position. So we already talked about tetralogy below. There's pulmonary atresia VSD, which is on that tetralogy spectrum, pulmonary stenosis, truncus arteriosus, patients that have had a Ross procedure. Sometimes they have conduits, and at times we can actually place a valve in those conduits if there is dysfunction or some other complex congenital heart disease. The indications themselves are if there's severe pulmonary stenosis or regurgitation, if there's some ventricular dysfunction, or if a patient has a pulmonary valve that's close to needing something done but is getting something else done at the heart at the same time. Next slide. So, the search for the ideal valve continues, but the things that we would like the most are, number one, that they function correctly, so that they have excellent hemodynamics, that they're durable and last a long time, that they don't need anticoagulation or blood thinners, and have minimal risk of infection or endocarditis. It's also nice because these valves tend to function better if they're implanted in the same location as the native valve, and if they have either growth potential, or what we've sort of settled on is if they're amenable to transcatheter intervention. Next slide. The choices, so the valve choices include pericardial valves, so it's the pericardium of a cow, so bovine pericardial valves, porcine valves, and a mechanical valve. Those are the big ones that we choose. Usually in the pulmonary position, we're going to go with a bioprosthetic valve, and that's for a few reasons. Number one, there's no anticoagulation needed. They overall have a lower incidence of having clots form on the valve themselves. They have very good durability, and there's also the future ability to place a transcatheter valve and even a valve-in-valve in the future. The downside is they aren't going to last forever. They tend to last, somewhere between 10 to 15 years is what we usually tell patients. And the reasons for failure include structural valve deterioration, fibrosis of the leaflets, calcification, and over time they can have either regurgitation or stenosis. Next slide. So let's just talk a little bit about durability, right? Like I said, they function pretty well. At 5 years, their freedom from reintervention is somewhere between 82 and 98%, and that's been validated by several studies that you can see here. And then at 10 years, it's about 52 to 83%. And the variability that occurs depends on many things. It depends on the type of valve used, the diagnosis of the patient, where the valve is placed, and also the age of the patient. Next slide. This is one of the largest multi-center trials that looked at bioprosthetic pulmonary valves and what their actual durability and reintervention rates are. So this is just looking at over 1,200 patients. And ultimately, they found that the biggest risk factor for needing replacement is the actual pulmonary valve being placed at a younger age. And, that's one thing, because there is no growth potential, obviously, the younger you are, the higher the likelihood that you're going to need a valve. And then, like I said, they kind of peak at their full function at somewhere between 10 to 15 years. Next slide. So the valves that we choose for each patient is truly tailored to the patients themselves. Older patients, we tend to use pericardial valves, or those bovine pericardium valves. That's the valve that's there in the top in the middle. Because those leaflets tend to be stiffer and can tolerate higher pressures. The porcine valves, or pig valves, which is the bottom left, they tend to perform better in younger patients because their leaflets are a little less stiff and they require a lower pressure to actually open up those leaflets. Mechanical valves are an option, but they're really rarely used just because of their issues with potential thrombosis, the need for lifelong anticoagulation, and honestly, if something goes wrong with that valve, in order to fix it, surgery is the answer as opposed to a trip to the cath lab. Next slide. So the pulmonary valve replacement surgery itself is a very common surgery in our field. It does often require a reduced sternotomy because most of these patients have had surgery before. It does require the heart-lung bypass machine, but the procedure itself takes roughly around 2 to 3 hours. The overall hospital stay is average at about 3 days, and the mortality risk is very low at less than 1%. Next slide. So let's quickly move on to who needs a pulmonary valve conduit. So this is any patient that actually requires that connection between the right ventricle and the pulmonary artery with a valve in between. It's pretty much very similar diagnoses that we talked about with pulmonary valves and very similar indications that Dr. Tompkins will go further into. Next slide. Again, just as we're looking for ideal valves, we're looking for ideal conduits as well. We want them to function well, so excellent hemodynamics, be durable, last forever, no need for anticoagulation, minimal risk of infection. We want it to be implanted where the native valve is, have growth potential, and again, be amenable to transcatheter intervention. Next slide. So types of conduits. We have the top two are homographs, which means these are vessels that actually come from cadavers. There are valve conduits, and some of us make these, and some companies make these with a valve, just like you saw the bioprosthetic pulmonary valve, and it is actually in between two pieces of tube or a Dacron tube. There are also PTFE valve conduits. So PTFE is like a Gore-Tex. And we actually create some of these in the operating room. There is one company that is starting to make these, but that's very early stages. And there's also something called Contegra, which is actually bovine jugular vein. So it's the jugular vein from a cow themselves. Next slide.
And Dr. Viegas, before we move on, a lot of patients in our community, when they hear about getting a homograft and it's from a cadaver, they have this ongoing, really important question, which is, do I have to go onto a donor list? How is it that you are able to get a cadaver conduit?
So these are actually often harvested at the time of procurement for a donor heart per se. So it's actually the leftover pieces or people that actually donate them themselves. The companies that help with kind of allocating everything, they also help with actually harvesting these. And then they go through several, some of these get decellularized. So that's the idea of trying to make it more inert. It's not 100%, but it's helpful. But then they are preserved in several ways, one of which is cryopreservation. So these are truly gifts from other people, but it also means that they don't have wide availability, which makes it a little bit difficult. And as you can imagine, the cost pretty high. So.
Great, thanks so much.
Yep. So this is just a quick look at some of the advantages and disadvantages of these three, and then I'll talk a little bit about the PTFE. So, homographs are great. They are available in a whole spectrum of sizes, and we just talked about how we get them. They are pretty resistant to infection. They have great hemodynamics because they are functioning as they were functioning from where they came. Their disadvantages is that they have limited availability. It's hard, especially as you can imagine, to find smaller sizes of these. While they exist, there's not that many, and they're quite costly. The Contegra or the bovine jugular vein, they're also nice because they have increased availability. Their sizes range from 12 to 20 millimeters, which is, roughly infant size to adolescent size. They do not cost as much as homographs. However, they do have a higher risk profile for infection as well as calcification. And then lastly, or on this slide at least, you have the valved conduit with the pig valve in between. These are nice because you can tailor them to whatever size. The problem is our smallest bioprosthetic valve is 15 or 7, sometimes you can find 15, but usually it's 17, so you're limited on size. And then you're going to be subjected to the structural valve degeneration that all porcine valves have. Next slide. And so the PTFE valve conduits, these are about 15 years in there, I guess, ever since they were introduced. So these are very specific valves. Not all centers do them, but these are actually valves that the surgeon creates themselves in the operating room. And we take thin Gore-Tex leaflets, so that's what's in the center of this tube, and we sew them on the inside, and then the outside is a tube that's made out of Gore-Tex. For us, we use this particular graft. It's just expandable. It's an expandable graft themselves, which is great in the cath lab because we can actually make them bigger over time and then place more and more valves inside and limit how many times we need to do open heart surgery. Next slide. So just looking at the overall durability. So overall, for all conduits, the freedom from replacement at about 10 years is around 50%, and their freedom from intervention is about 40% at 10 years. If you look at just pulmonary homografts and the Contegras and the aorta homografts, pulmonary homografts in this position tend to function the best. At 10 years, their freedom from intervention is about 80%. At 30 years, it's about 66%. So they do well. But as you can see, they're pretty close to one another. And, depending on the anatomy of the patient, we'll choose which one is best. Next slide. There hasn't been a big study to compare the PTFE valve conduit, so I just wanted to do this separate. And the other thing is, because not all institutions have these available, most of the data comes from single institution studies, but they perform very well. They have a 92.7 freedom from reintervention at 5 years and 88% freedom from reintervention at 15 years. And like I said, their biggest selling point is not only are they amenable to future transcatheter interventions, they're amenable to multiple transcatheter interventions, which make them very versatile. Next slide. So which one do we choose? Again, just like with the pulmonary valves, we're going to tailor it to each patient, the age, the size, their anatomy, medical history, patient preference, and of course, the surgeon and institution preference all play a role in this. So, next slide. The surgery, this is just really short, but it's very similar to pulmonary valve. It is a common surgery that we do. It's a reduced sternotomy, again, requires a heart-lung bypass machine. The procedure takes about 2 to 3 hours, and generally the hospital stay is about 3 days with a very, very low mortality risk. Okay. All right, and with that, I'm going to pass it on to Dr. Tompkins so she can tell us how these patients do as they continue to grow.
Thank you so much, Dr. Viegas. So Dr. Pruetz and Dr. Viegas have really planned to showed a landscape, if you will, of the patient population that we start seeing as patients age and grow up and come into the adult clinic. So we'll do next slide. And for most of the patients that I see that I'm evaluating for pulmonary valve disease, by and large are going to be congenital heart patients. So meaning that the pulmonary valve became dysfunctional related to born disease, that they came with congenital heart, less so for acquired, but does exist. So we will have some cases of that with the patient maybe getting a valve infection. But you can see that with even intervention, many of those valves, as Dr. Viegas pointed out, are not forever valves. And so we do need to keep a close eye and keep people engaged in care, because they may need that reintervention and trying to figure out the timing. So there's two main questions that I really consider when I'm evaluating a patient, when I'm looking specifically at the pulmonary valve. And number one is, what's the function of that valve? Is it too leaky, meaning that it's starting to develop severe regurgitation, or is it too narrowed, meaning more severe stenosis, or a combination of the two? And then I'm looking at, is it their native pulmonary valve, or is there a prosthetic pulmonary valve in place? Have they already visited my surgical or interventional colleague? And so I'm going to be thinking a little bit differently about their function and maybe potential interventions down the line based on those questions. Next slide. Okay, so starting off with pulmonary valve regurgitation. So regurgitation equals leak. Okay, so really that the valve is not closing well and blood is able to go backwards, if you will, into the right ventricle instead of all the blood going forward out to the lungs. And what this is going to result in over time is right heart enlargement or dilatation, and can eventually lead to dysfunction. And this is because this is a volume overload. That heart is not meant to carry that much volume over time. And patients may start to experience symptoms of exercise intolerance, where really their stamina is not able to keep up, abnormal heart rhythms. And end stage is something that we really call right heart failure, where they may be retaining a lot of fluid on the body, really not feeling well, and even having symptoms at rest. And Adam, if you advance, I'm just going to show some examples of how we evaluate the pulmonary valve. Next slide again, or click. So our workhorses really are the echocardiogram and the cardiac MRI. And I just tried to label here on the MRI image where the pulmonary valve is. And you can see above that's the pulmonary artery, and then below that's the right ventricle. And we can see that this is a leaflet that is not sealing well. And so there's a lot of backflow coming into the right ventricle. And by MRI, we're able to get more quantification and determine regurgitant fraction. And that's how we help determine severity. And then on the echo, kind of a similar image, but you can see more color there. And there's this whole rainbow. And you shouldn't be seeing a rainbow. So what's that implying is that there's to and fro flow across that valve. And really, there is no seal at all. It's almost like an unguarded orifice. There's really not any pulmonary valve leaflet tissue. So that's a pretty extreme example of severe regurgitation. Now, children live this way for quite a while, but eventually that will catch up with them in adulthood, and they'll start to manifest those indications that I mentioned, and why it becomes important to start considering timing of intervention. Next slide, or next click. So with regurgitation, so it can be the native pulmonary valve, and this is often after a childhood repair of congenital heart disease. So most commonly, it's tetralogy of Fallot. And as Dr. Pruetz mentioned, if we're doing things like a transannular patch, we may not leave much pulmonary valve tissue, but they do fine with that if they don't have a lot of stenosis. But eventually that regurgitation, like I mentioned, will catch up with them in adulthood. Or congenital pulmonary valve stenosis that might underwent a surgical or balloon valvuloplasty where they enlarge the valve. And again, alleviating any of the stenosis or blockage to blood flow, but then they're left with regurgitation that does take a few decades where we start to think about intervention at that time. Now, the next is dysfunctional prosthetic valve, and meaning a previous pulmonary valve replacement. This can include the vast array of pulmonary homograft conduits or all the other different conduits that Dr. Viegas had mentioned, in addition to the surgical bioprosthetic pulmonary valve replacements that could be either surgical or transcatheter, which Dr. Nageotte will be going through shortly. And dysfunctional, again, this is just really important with these dysfunctional prosthetic valves. The reason is that there is going to be progressive wear and tear or tissue degeneration. These are non-mechanical valves, and again, these are not forever valves, so this is all expected and anticipated. Okay, next slide. So then other condition is pulmonary valve stenosis. So this is where the valve is too narrowed and often can become calcified. It's not opening well. And that stenosis is going to result in kind of similar manifestations as regurgitation, but instead of being a volume overload of the ventricle, it's going to be more of a pressure overload. The ventricle has to work that much harder to squeeze blood flow through that little narrowed passageway. So that's going to lead to right heart hypertrophy or muscle enlargement. And then we can start to also cause right heart dysfunction. Patients symptomatically will have similar symptoms as we'll see with severe regurgitation, including that exercise intolerance, abnormal heart rhythms. And then the end stage is quite similar, right heart failure, again, manifesting as volume overload and feeling pretty symptomatic at rest and not doing well. I show a classic picture here on a CT, really highlighting the brightness. So that brightness is calcium. And what we can see here is a prior prosthetic pulmonary valve that had been put in a patient. And this is the wear and tear that can happen to these valves over time. So this is the degeneration or the calcification. And then that other view of the valve in FOSS really showing how that opening really gets narrowed down. And so not a lot of area then for that blood to push through and go out to the lung. So I always equate to traffic for some reason being in Los Angeles that we're on a major interstate at 405, and that instead of a 5-lane highway, maybe we're going down to a 2 or a 1-lane highway, and then that's where we really need to go in and intervene. Next click. So similarly, we can see this with native pulmonary valves. So this could be progressive congenital pulmonary valve stenosis that wasn't previously repaired, but was advancing as the patient is getting older and may ultimately need something done. More commonly, dysfunctional prosthetic valves are probably by and large where we see more stenosis in the adult clinic. And this is going to include a pulmonary homograft conduit or bioprosthetic pulmonary valves, again, surgical or transcatheter. And again, that little caveat, this is all anticipated and things that we are looking for, especially as patients are nearing that 10 to 15 years or beyond, as Dr. Viegas mentioned, because we're kind of anticipating that's a typical lifespan of many of these valves. Next slide. So when we think about options, once we have determined that patient has met indication to get a new pulmonary valve, really it's two main avenues. It's either surgical, which is open heart, or transcatheter, which is transfemoral through the groin. And so we're very fortunate now in 2025 to have a lot more options from a transcatheter perspective that we get to think about, in addition to all of the surgical options that Dr. Viegas just went through. And Dr. Nageotte's going to mention this a bit, but this is really important to understand that this landscape has changed so dramatically, really in the past 15 years, and continues to evolve with new devices approved just as recently as 2 years ago. So this is truly a remarkable field, and why the benefit of coming to a place like Cedars with a multidisciplinary team that includes all the experts that you see now, because we really go through all of the different nuances for determining the best valve type for patient. So it's going to be based on anatomy, the surgical or procedural risks, whether or not there's a valve infection, patient preference, and then obviously the expertise that's there. And so this is why, again, it's not a one size fits all by any means for our patients. And I do want to highlight again, mechanical valves and surgical repairs really aren't favored. An issue with mechanical valve too is lower pressure on the right side of the heart relative to the left side, which is mitral and aortic valves, which are much more common to have mechanical options. And so the risk of that valve thrombosing in the pulmonary position, even with anticoagulation, is still quite high. So that's why it is not standard of care to do these other options, and why really it's focusing on all the valves that you're hearing about today. And so without further ado, I think we'll move on to Dr. Nageotte to move into the space of all the things that are happening in the transcatheter arena.
Awesome. Thank you so much, Dr. Tompkins. So if you want to hit the next slide, I'll be going over the transcatheter pulmonary valve replacement options. And so when we're talking about transcatheter, what we mean by that is that what are our non-surgical options? So when we say transcatheter, we utilize catheters or soft tubes to enter through the veins, usually through the leg, but sometimes through the neck, to maneuver through the heart and get into position across the pulmonary valve. We do this on a beating heart, so we're not needing to stop the heart or anything like that. If we're successful in replacing the pulmonary valve, usually the patients will stay overnight and most likely go home the next morning after a period of some observation. Usually it is not a particularly painful procedure, and the morbidity is relatively low for those patients who are a good candidate for it. And as Dr. Tompkins was mentioning, really the landscape has completely evolved over the past 15 years, and over the past 5 years it's continued to evolve. And what we can offer now is significantly different, and this landscape will continue to evolve into the future. So with that in mind, if you in my thing, next slide. So looking at the historical context on the right side of the screen, what you'll see is basically the full spectrum of all the transcatheter pulmonary valves that we have. At the top, we have the two balloon expandable valves, which are the Medtronic Melody valve and the Edwards Sapien valve. And then we have some self-expanding valves. And historically, we first started with balloon expandable valves, and our targets with those were mostly within these conduits or bioprosthetic valves. But what we found is that about 75% of patients were not being able to be treated with balloon expandable valves alone because the outflow tracts were so large. And that really pushed for the development of self-expanding valves. So over the past several years, the number of self-expanding valves continues to develop. There you see the Harmony valve, and then at the bottom you see the Altera self-expanding pre-stent, which are the two valves that are available in America. But I put there are three other valves in that picture that are kind of international valves that I'll touch on at the end as well. If you could hit next slide. So the first transcatheter valve period, whether it's pulmonic or aortic, that was implanted was the Melody valve, and that was implanted in the year 2000 by Dr. Bonhoeffer. And if you could advance the animation one, so this is the how they are made. You have a platinum iridium stent, and they take the bovine jugular vein of a cow, so a jugular vein from a cow, and they sew that into the stent. This is hand sewed into place. This is similar to the Contegra graft that Dr. Viegas was talking about earlier. This comes in sizes that are implanted between 18 and 22 millimeters, typically in conduits or within bioprosthetic valves, and less frequently in a native outflow tract. These are outstanding valves, and they have wonderful durability. But what we've noticed over time is they seem to have higher rates of endocarditis, which is becoming more and more of a concern. And so wherever possible, our field has actually started to move away from utilizing these valves, unless for the right patient it is still a good option. If you can hit next. So this is what they look like on their ensemble or delivery system. You can see that is how they go in, and then on the very bottom of that screen you can see the balloon expanding and then slowly deploying the valve. And then if you could advance the animation one more, this is the same kind of thing, just within a heart. You get the valve in position, you inflate the balloon, then you deflate the balloon, and you take everything out, and the valve stays in position. Next slide, please. So more frequently now, we've gone more often to the SAPIEN valve, which is a valve that is very, very frequently used in adults for transcatheter aortic valve replacement. So this is a balloon expandable valve with bovine pericardial leaflets in a cobalt chromium frame. So this is also used similarly in conduits, bioprosthetic valves, or actually now in some native right ventricular outflow tracts. It's a larger delivery system, but the size of the valve is also much larger, coming between 20, 23, 26, and 29 millimeters. You see in the animation how we are able to manipulate the catheter up through the heart this is a picture coming from the femoral vein up the inferior vena cava through the heart, and then we deploy the valve actually across the pulmonary valve once in position. This has not been utilized in the pulmonary position for all that long, so we only have good 5-year data, but the 5-year data is actually excellent, with 95% of patients with mild or less regurgitation and significant improvement in patient outcomes in terms of their functional assessment. So in those patients in whom SAPIEN valve is an option, it's proven to be an excellent option, these patients, and we'll need to follow with time to make sure that long-term durability appears to last as long as it's seeming to in the aortic position. If you don't mind hitting the next slide, please. So those first two were what we call balloon expandable, which is kind of what the animation was showing, meaning these valves are mounted on the outside of a balloon, they go into position, and we inflate the balloon. Those valves only go up to 29 millimeters, and what we're finding is that many patients actually need much larger valves, and those valves would not be able to seed safely into the patient. So there's been the development of what we now call self-expanding valves, meaning when they're uncovered, the valves pop open and are shaped, most of them are shaped kind of like an hourglass, and these are designed to go in the native outflow tracts or patched outflow tracts of patients with pulmonary valve disease. This is the Medtronic Harmony valve. This is one example of one of these self-expanding valves. It has a polyester's knitted onto a nitinol wireframe, and the valve itself is not really shown here. It's on the inside of the valve. It's porcine pericardial leaflets. These are designed to accommodate much larger landing zones. And as well, these have not been implanted for very long either, so we only have about 3 to 4 year outcomes. And those outcomes are demonstrating low levels of pulmonary regurgitation, less than 4%, and very high rates of procedural success. With these procedures, the whole name of the game is pre-procedural planning. So utilizing MRI to figure out which patients are the right timing of when they need a pulmonary valve replacement, and then CT scans as well, in addition to MRI, typically, in order to plan our procedure and see who would be a good candidate. Because again, technically, the technical success rates are so high because we spend so long ahead of the procedure making sure we're determining who is a candidate for this valve and who would actually not be a great candidate for it. If you could advance the slide one more. Again, this is just showing the inflow. Advance again, please. Just showing the sizes. It's much larger, getting up to about 48 millimeters. Or 39 millimeters with the smaller Harmony valve. So versus the 29 millimeters with the SAPIEN, these can treat much, much larger outflow tracts in patients. Next slide, please. And this is the Edwards valve, or this is a pre-stent in which we put a SAPIEN valve. So this is called the Altera pre-stent. Very, very similar idea to the Harmony valve. There is certain pros and cons to each of those different valves. And the design though is similar. This is a self-expanding nitinol wire with a PET covering as opposed to polyester, and it's designed to remodel in the right ventricular outflow tract in which to land one of those SAPIEN S3s that I was showing 2 slides ago. Again, this is for larger. This is larger, and it's to accommodate the larger landing zones. Additionally, the outcomes have been excellent with very low rates of pulmonic regurgitation and high rates of procedural success. If you could advance, I have some videos showing the implantation process. So this is inside of the right ventricular outflow tract where the Altera is being released there. You can see at the beginning here, at the bottom of it's being constrained, and we then slowly release the pre-stent. In the middle of the pre-stent, you can see some dots. If you hit if you advance it one, please. Now we have a sapien valve that's then being implanted within the Altera, which has remodeled the outflow tract so that we can put a valve inside it. And that sapien valve is being expanded right now, or right about now. And then perfect, if you could advance it one more. This is a final picture showing that there's no regurgitation after the valve has been implanted. Next slide. In the interest of time, I'm going to kind of skip through this. These are just some international innovations. There's 3 different valves, the Venus P, the Polsta, and the Zenith valve from China and Korea. Very, very similar idea to the valves we have here in the United States. But the more valve options we have, the better for us. So also making sure we're keeping an eye on these valves and seeing their durability. Next slide. So just to summarize, the transcatheter pulmonary valve replacement is significantly advanced. The number of treatment options for which patients has come a long way over the past 15 years, and even over the past few years, has continued to evolve, and I anticipate continued evolution in this field. High rates of procedural success, improvement in quality of life, with the goal of decreasing the total number of median sternotomies and surgeries that are needed. But really, what the goal of all of this is to try to pick the right option for each individualized patient to set you up for a lifetime of success, whether that be surgical or transcatheter, really going to a center that works as a team and has all the options available. All right, perfect. Next slide. And you can just advance it one more. Now we can go to the case examples. I'll kick it to Dr. Pruetz for the first one.
All right. This is going great so far. So pediatric case of tetralogy of flow with pulmonary atresia. That means that the child was born without a pulmonary valve. It's completely obstructed. And so in these scenarios where you have no outflow tract, from the right heart to lungs, you have to provide some source of pulmonary blood flow. And in this case, we used a fetal structure called the patent ductus arteriosus. We kept it open with the medication, and then we put a stent in there, like one of the stents that Dr. Nageotte showed you, but much smaller, to kind of give flow for a temporary time period to the baby's lungs so that they can maintain oxygen levels. Go ahead to another click. And so this is the whole idea of stage repair. So by stenting the ductus, then we can get this child out to 6 months of age before actually having to do surgery, at which time Dr. Viegas can perform a complete TOF repair by patch closing the VSD shut and placing an RV to PA conduit. In this case, it was an aortic homograph. It was approximately 13 millimeters in diameter, and they take down the PDA and the stent at that time because they're no longer needed. Next click. And then this child progresses to about 3 years old. And unfortunately, the largest size conduit that could be fit in at that time, based on the patient's size, was 13 millimeters. And now the patient's growing rapidly and starting to develop conduit stenosis. And so we don't want to have to take this patient right back to surgery. So we're going to actually go to the cath lab now. And if you go to the next slide. Oh, actually, before we go back to the cath lab, we're going to do, click another time. We'll do some more investigation. We can do 3D reconstruction of the pulmonary arteries and then stenting within the conduit, which actually gave the child more time. So by not having to replace the valve at that time, we actually stented open the conduit to allow more flow to the lungs temporarily. If you go to the next slide. And then, eventually this child now at 8 years old, even with the stent in place, there's now, with continued growth, more obstruction. The right heart is starting to become dilated, thickened, and so there's not a really great transcatheter option. This is a patient that at that point we would refer for surgical repair, and I think Dr. Viegas did a really nice job of going over the surgical options for that.
Okay, and then to give round it out with an adult example. So we have a repaired tetralogy, a Fallot patient coming to clinic with pulmonary valve regurgitation. So he was repaired via transannular patch that left him with longstanding severe pulmonary valve leak or regurgitation. And he came to clinic with new activity intolerance and palpitations, really not feeling well. And he was found to have a severely dilated right ventricle. And Adam, if you could just click once for that echo image and another one more click. Great. And so the echo image that you can see there on the left, again, showing that rainbow of flow across the pulmonary valve. So really to and fro flow. If we look at the MRI next to that, I showed you the RV relative to the left or right ventricle relative to the left ventricle, and it is significantly larger. It should actually be a little smaller than the left ventricle, so letting you know how dilated that appears. And then on the MRI moving image, again, we can see kind of that to and fro flow across the pulmonary valve, that big right ventricle. And then on a CT angiogram, just because, we have to get all the imaging, but I'll go why we did the CT here in a moment. What's really striking is that you can see there's no pulmonary valve leaflet tissue at all. So there's actually no pulmonary valve that was removed at the time of the transannular patch and complete repair of the tetralogy of Fallot back when he was a child. And you can see the large patch actually on the top right above where the pulmonary valve would be. And so it's nice and open, but it's quite dilated now. And that's going to play a role into some of the transcatheter options, as Dr. Nageotte mentioned, because with the balloon expandable valves, there's no place for a valve like that to sit. There's no anchor point. So he really wouldn't have had transcatheter options historically and would have been referred for a surgical valve replacement. However, being 2025, if you go to advance to the next slide, we were able to discuss all of his options, and he was determined to be a candidate for the Harmony valve that we mentioned, and the patient really wanted to avoid another open heart surgery. And so after all the careful evaluation, including the CT scan for us to determine anatomical suitability, Dr. Nageotte was able to deliver a Harmony valve there and to kind of have that one CT scan just for a location reference so you can see how that stent is sitting within the heart. And then on the image next to that, that's actually intracardiac echocardiogram. So I'm showing you all the bevy of ways that we can evaluate the pulmonary valve. And this is at the time that the Harmony valve was released. And look, he suddenly has beautiful prosthetic valve leaflets that look excellent. There's absolutely no leak, so we don't see any rainbow of flow, at the top of the screen, which would be back into the right ventricle. So it was an excellent procedural success, and a patient was able to go home the next day from the hospital with just a Band-Aid on the leg. So obviously a big change from an open heart, and why these new valve technologies are so significant for this patient population and being able to have more options. Next slide. So he was seen in clinic about a month later, and so I have the echocardiogram on the left that shows that right ventricle really dilated before the Harmony valve implantation, and then just a month later, you can visually really see how nicely there has been some reverse remodeling of the right ventricle, and that size has actually normalized, and patient is feeling excellent, can't wait to go back to snowboarding come this January, and really looking forward to that. So really exciting for him, and an exciting time to kind of be in this field, as we just have a lot of ways to be able to treat patients and really get them back on their way, and having an amazing quality of life really for the long term. Now, this patient will need to continue to see me. So he's not cured, repaired. And so that's something that I always emphasize with all my patients, is that you do need to stay engaged in care, and we need to continue to keep an eye. And as Dr. Nageotte mentioned, the Harmony valves, those were FDA approved in 2023. So we don't have a lot of long-term data. We have some clinical trial data that's a few years out now. These valves are performing quite well. However, we don't have the length of follow-up like we do for surgical valves. And so I do tell patients, that's important that we keep an eye, and they're going to kind of teach us as first generation with these new devices of how they really do in the long term. So that's a little bit of the flip side, right, of taking on new devices. There's just a little bit more uncertainty and unknown that we do discuss as part of our consenting process as we go through all these options with patients. Okay, so I think with that, we're ready for Q&A.
Great. Well, thanks so much to the Cedars team. That was really fascinating. I love how you ended on the note with the snowboarder getting back onto the mountain, right? That is just a great way to end the formal prepared remarks and get right into the Q&A. And we got some great questions. Julie sent me three emails about this question. She's from China. I think we just have to answer it explicitly, even though you talked about it earlier. Can a mechanical valve be used in the pulmonary position and last forever in young patients? If not, which valve is usually used for pulmonary valve replacement? What is the average time for a reintervention?
So I'll go ahead and take that question. So, as we said before, we're still all in search for that ideal valve, and mechanical valve would be great. Sadly, it doesn't have any growth potential at all. And so that being said, it won't last forever in a young patient because eventually that patient will outgrow the valve. But also, very importantly, and Dr. Tompkins touched on this as well, the pulmonary or the right side of the heart has very low pressure. So this mechanical valve itself is just at a very high risk for clotting or having thrombosis. So it also doesn't make it ideal, and comes with the added cost of anticoagulation, which can really limit activities, especially in young kids, and that'll have a lifelong effect as well. So usually the valve that we use is a bioprosthetic valve, and again, they are quite durable, and it's usually depending on the age, right? So if you're older, I would say it lasts about 10 to 15 years. Patients that are younger, it's going to depend on how much they grow, and if potentially they need another valve in that interim. But they can structurally last somewhere between 10 to 15 years, and with that, it's only about 50% chance needing to be replaced.
Great. Thanks, Dr. Viegas. This one is a really interesting question from Kim. She asks, if I gave birth to a child with a congenital valve defect, am I likely to do that again with my next son or daughter?
I can take that one. Yes, there is increased risk, but it really depends on exactly what the diagnosis is. We do know that congenital heart disease, when you have one child with it, you do have, with subsequent pregnancies, increased risk of recurring. But what I like to say is that that's not given. I think you should get good genetic counseling. There is some tests that can be performed prenatally or even preconception to kind of look at those risks. And then I definitely recommend getting screening during the pregnancy, including a fetal echocardiogram, to figure these things out before the baby's born.
Great. Thanks, Dr. Pruetz. This comes in all about technology, and Colin asks, is there any new med tech being worked on that would enable a pulmonary valve replacement to grow with an 8-year-old child needing surgery?
Yeah, I can start on at least looking at the transcatheter options. And unfortunately, none of the transcatheter options grow on their own, but they can be grown further. So it is not uncommon that we could put in a pulmonary valve, even in someone as young as 8, that can be dilated further. 8 is a little on the young side, but there is technology being developed out there. It's not available yet, but there are valves that can be put in even at younger ages, 2, 3, 4 years of age, that can be further dilated. Those things won't grow on their own, but I can kick it to Dr. Viegas if she's got any comments on any surgical valves that might be able to do that.
Yep, and then from a surgical perspective, any valve that's going to grow, there is an RV to PA conduit that had been reintroduced to the market. And the idea was that it was a conduit with a valve inside, and eventually the graft material actually resorbs and is repopulated by native tissue. That was called the Zeltis valve. It is still very early. Their first group of patients only had 1 year follow-up, so there's more to come because they have taken it back and they're adding more to that. But on a different front completely, the world of partial heart transplants does exist. And, that would be, say someone is getting a heart transplant, but their current heart actually has a good pulmonary valve. We would actually take that valve and part of the pulmonary artery and part of the right ventricle, and we could implant it in. There's a lot more steps to it. There's lots of stuff involved. It will require some element of immunosuppression. We're not really sure about that, but that's one of the forefronts from the surgical perspective in this field.
Wow. And for the patients and the parents on the line, this is really what I consider to be such a strong point about having a very good heart team to help manage your valvular defect, because you're getting feedback from a group here, whether it's on the interventional side or the general cardiology side or the surgeons. I had never heard about partial heart transplants, Dr. Viegas, so that is fascinating to me. And this was a question that came in about the Ross procedure. Julie asks, is DPH, decellularized pulmonary homografts, or CH, cryopreserved homografts, used for pulmonary valve replacement in the Ross surgery in the United States?
Yes, actually, they're both available. They're just, what decellularized pulmonary homograft means is basically the DNA or as much as possible, and the cells of the cadaver have been removed so that it will be inert, so that it's not supposed to stimulate the recipient's immune system and cause any low-level rejection, but more importantly, antibodies in that patient. And almost all of our homografts that we use, especially, are cryopreserved. So yes, they're being used.
Great. And on that note, I want to respect everybody's time. We're going to conclude the webinar, but I'd ask you not to just jump off the line just yet, because I'm going to ask you to complete the survey for all the patients and the parents joining us today. And I also want to stop and just thank Dr. Tompkins, Pruetz, Viegas, and Nageotte for taking the time to really help our community understand this idea of congenital pulmonary heart valve disease and how to manage it for your entire lifetime of yourself and or your child. And so on that note, thank you, Dr. Nageotte, Dr. Viegas, Dr. Tompkins, Dr. Pruetz. Thanks for being with us today. And we'll go ahead, and if you just stay on the webinar for another 10 seconds, you're going to see a survey pop on your screen. As we always say here at HeartValveSurgery.com, keep on ticking. Happy holidays, everybody. Talk to you soon. Bye-bye.
Hi, everybody, it's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel, watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.